Hello, everybody. Good morning, good afternoon, good evening. Welcome, everyone, ladies, gentlemen, guys, gals, and non-binary pals. I'm Monique Springer, Project Officer with UWIHARP, and I'm joined with Keelia Anderson, our Project Assistant. A very special welcome to our students, staff members, colleagues with the National HIV/AIDS Commission, off-campus partners, repeat visitors, and to our new guests. UWIHARP is the HIV Sexual Health Unit at UWI, and we seek to positively influence the sexual and reproductive health and wellness of the university population and the wider Caribbean society. Our primary focus is the development of sexual health literacy among the community through programs such as our digital dialogues. These are sexual health conversations, and they will be held during this semester. They include the S-Files Sexual Health Discussion Series on a wide range of topics, and the Shock Series, which will focus on sexual health issues among our Caribbean populations during COVID-19, especially the vulnerable populations. And you can look out for our flyers on our social media platforms, which include Facebook, Instagram, the UWI app, and through UWI student emails. There are a few participating guidelines. All mics should be muted at this point and videos turned off. Q&A will take place after the presentations and the mics will be unmuted. We ask you to post your questions and comments during the presentation in the chat pod located at the bottom of the screen. We aim to address as many as possible at the end of the presentation. Alternatively, you can message me directly if you prefer. For those questions we can get to, please email them to uwiharp@cavehill.uwi.edu before the end of the day, and we will address them shortly afterwards. The sessions will be recorded, and the recordings will be posted afterwards on our social media platforms, including our YouTube channel, UWIHARP Cave Hill. These will be done without the Q&A to protect participants' confidentiality. Please note that we cannot guarantee confidentiality in this public forum among participants, so be cautious about what personal information you disclose about yourself and others. It is safer to talk in general terms. Please complete the evaluation form that will be sent to you after the session. You can suggest topics that you're interested in for us to facilitate. And we have a few rules, some of which have been adapted from HIV 2020 online. UWIHARP's digital dialogues provide a safe space to address a range of sexual health topics using a sex-positive approach. We encourage participants to share their knowledge, experiences, and opinions in a respectful manner. You may disagree with views highlighted today. However, please be respectful of other outlooks, regardless of your religious or moral beliefs. Let us be mindful in the way we discuss sensitive topics. UWIHARP operates on a zero-tolerance policy for any kind of abusive, discriminatory, belligerent, or disparaging comments or actions that may cause distress to presenters and our participants. Persons who engage in any undesirable behaviors will be immediately removed from the webinar unannounced. UWIHARP's guiding principle is to first do no harm. And I'm really delighted to start our first Shock series discussion, the sexual health online conversations about COVID. And today we will be looking at sexual health as from the perspective of our colleagues from the Caribbean Family Planning Associations to see what their realities are on the ground, and as it's called, stories from the trenches. And today we have two very special guests, Ms. Joan Burke, who is the Executive Director at the Belize Family Life Association. Ms. Jo Burke-Skeen, Belizean, holds an associate degree in arts and sciences, certificate in sexual and reproductive health, a first degree in community, and a master's degree in public health. From 1991 to 2003, she performed duties related to community health, emergency preparedness and management, women's health and development, and HIV and AIDS response with the Ministry of Health in Belize. From August 2003 to date, Executive Director, she served as Executive Director of the Belize Family Life Association. She's represented the government, civil society, and people of Belize on many occasions, locally, regionally, and internationally, addressing various aspects of sexual and reproductive rights and health. She's also the recipient of the 2007-2008 Madison Who's Who Executives and Professional Award. And we have also Mr. Anderson Langdon, and he joined the BFPA, known as the Barbados Family Planning Association, in 2009. He is currently the executive director and works closely with the BFPA team to better utilize its information and data-rich management information systems for strategic social interventions in sexual and reproductive health. While at the BFPA, Anderson has been part of many collaborations with regional and international organizations, such as the Pan-Caribbean Partnership Against HIV, PANCAP, the Caribbean Family Planning Affiliation, the International Planned Parenthood Federation, United Nations Population Fund, United Nations Children's Education Fund, United Nations Development Program, and the United States Agency for International Development. Now, as I said, today we will be looking at sexual health services during COVID. And, we've been following some of the global chatter on sexual reproductive health. And one of the things that I discovered throughout the pandemic and just across the globe, as I said, that SRH services, sexual reproductive health services, were not prioritized during the COVID response. We would like to hear from both Joan and Anderson today if this was their experience. Certainly, we've heard how contraceptive manufacturers closed during the COVID-19 lockdowns, various lockdowns, and this affected the supply chain and distribution of their supplies. And this included port processing challenges, customs clearance challenges, international and domestic transportation and delivery halting. As a result, there were challenges to import and export, causing restrictions. And this resulted in stockouts or shortages with family planning commodities. We also heard about reduced access to SRH services, especially for women and girls, which prevented them from using their preferred contraceptive choice or any at all, resulting in unintended pregnancies and exposed increases in STI transmission. So what I'll do now, I'll invite Joan to share from her perspective what the realities are continuing to be in Belize, and things that, what worked with them, for them, and any challenges that they incurred. So Joan, I'll hand it over to you. Thank you.
Hi, good morning or good afternoon. Thank you so much, Monique, for this opportunity. Okay, I am Joan Berkstein, Executive Director of the Belize Family Life Association. And we have been in existence for over 35 years, basically providing sexual and reproductive health services to the country. Just a little background on Belize. Belize is bounded north by Mexico and southwest by Guatemala. So we are basically in the middle of Guatemala and Mexico. We have a population of 450,000 people, and the size of the country is 8,867 square miles. Our main source of revenue is tourism. So in February, when we started actually monitoring what was happening with COVID in the United States in particular, and Europe, because those are the areas where a number of our tourists they come from, our borders were closed. So all the cruises and all that, those were canceled. And then we had our first case diagnosed on March 24th. There were some immediate actions taken, as I said, closure of the borders. We had the closure of our airport, and that could have been probably in the first week of April. Our airport has just been opened on October 1st. So with the closure of the borders and we're not being able to have air transport, indeed, Monique, we did had some challenges in having to import and to receive our commodities. To date, we have 2,585 confirmed cases, 1,580 recovered, 966 active cases, and 39 deaths. Now, with that kind of epidemiological profile, what the government did was impose very, very strict measures. We had total lockdown for almost 3 months. Which then prevented persons from traveling within their districts and cross districts, and that also included traveling or going to medical facilities for services not considered emergency. And of course, even at the level of the conversation at the House of Representatives, sexual and reproductive health is not considered an emergency. So the discussion held in terms of planning for the response did not include sexual and reproductive health. Luckily for us, we had representatives from the United Nations Population Fund, who we have an excellent working relationship with. And we also have the Chief Executive Officer in the Ministry of Human Development and Social Transformation, who has an appreciation of the importance of sexual and reproductive health. So despite the lockdowns, BFLA was given an emergency, what they call an emergency pass, that we could have traveled within Belize City as well as to the districts. So with the support of UNFPA as well as the Ministry of Health, immediately we set up the sexual and reproductive health mobiles. We had limited supply of contraceptives, and the Ministry of Health donated some contraceptives to us that we were able to go into very rural communities. So in order to distribute the commodities or contraceptives free of cost. We also combine those with the cervical cancer screening, because that helped us to identify any other conditions that may exist, particularly among our women. Because what we also saw was an increase in domestic violence or gender-based violence, which also increased the risk of women to have unprotected sex, to end up with STIs, as well as unintended pregnancies. Now, addressing that became extremely challenging because having been locked down and many of these services not being available, these women and girls were locked up with their abusers. What we also saw was, particularly for our younger population, there were reports of stuff like telesex. We had increased reports of incest as well as rape. We worked with the organizations that represent certain key populations. One such population was the female sex workers. Because of the lockdown, because the sex workers, they were no longer able to provide sex for income, a number of them are from the neighboring Central American countries. so they were unable to return home. That then made it extremely difficult to survive in Belize without having income, especially those who had their independent living quarters. So what they ended up doing was providing sexual favors to their landlords in exchange or in lieu of their rent. What we had to do then was to work along with an organization that represent or work with female sex workers in Belize and providing them with condoms and emergency contraception. We also had to reach out to those organizations that worked with MSM, trans, and other key parts, because it would have been extremely difficult, even with the minimal services that were being provided by the Ministry of Health, for these populations to access these services, simply because traditionally they would come to BFLA or other civil society organizations to access these services. So not being able to travel also made it extremely difficult for them to access these services. Now, with the support from the Ministry of Health, as I said, with the commodities or contraceptives, we found out that it was much easier to partner with other organizations who were doing the pantry distribution, because what the government did, particularly for those persons who worked in the tourism sector, the ministry or the government of Belize provided the unemployment support and also the pantry. Now, what we realized, it was very evident, again, even with the pantry, that SRH was not considered any at all. Whilst the packages included food and cleaning agents and all that, there was absolutely no consideration given to issues such as menstrual hygiene. So things like sanitary pads and other stuff for menstrual hygiene, those were not included in the packages provided to the communities. There was also no contraceptives, no condoms, no lubes, any such things were not included. So it gave us an opportunity for us to work along with other organizations that were distributing these packages, particularly Power the Productive Organization for Women in Action, where we were able to slip kind of very discreetly included contraceptives and lubes, as well as emergency contraceptives in some of those packages. We had to, with the support of UNFP, we ended up contracting the services of a licensed counselor to provide telecounseling, particularly for those persons who were in situations of gender-based violence, as well as young persons who were battling being locked up and having to manage their own sexual health. BFLA has a program called BFLA After Dark, where we promote sexual health, but also include it as pleasure. So we take away the disease focus from sexual health and replace with pleasure. So we sell pleasure toys. What we did in response to COVID was a 25% discount on the price for the pleasure toys. And we actually did delivery services. So persons would go online, make their purchase, make their payment through the bank, and we would then go and deliver these pleasure toys, and also use a number of social media platforms, and these were managed by our youth advocacy movement to engage in healthy discussion, so that we can allow persons to express as well as ask questions regarding their sexual and reproductive health. And that allowed us also to direct individuals in their respective communities as to who they can get certain products. Because what we had done was to work very closely with persons in communities to also make SRH commodities available. Of course, we were faced with a number of challenges because BFLA is only one organization, and reaching some very hard to reach communities wasn't possible. There were a number of reports being shared. We had reports out of our quarantine centers, especially the centers that are being managed by the government, where we felt that there were violations, especially among our women and children, because these centers were managed by police officers and immigration officers that I think they weren't, they may not have been trained as to how to respond in emergency situations, or even if they were trained, I guess COVID created an environment of fear in many individuals. So we had and continue to have border jumpers. We don't know what is their status. So the staff being placed at these quarantine centers, I think they did not, in some cases, managed certain situations as professionally as we would have liked. And in that manner, then they violated a number of our border jumpers. Luckily, in some instances, we had the social workers who were a little bit more compassionate among the women and children, because these persons are running away from their homes for whatever reason, running away from neighboring Central American countries for whatever reason, and probably feel that, you know, their Belize is safer for them for whatever reason they believe that that is as well.
Hi, Joan, sorry to interrupt, but you know, time goes very, very quickly when we're having fun. So I'm going to give you about 5 minutes then to wrap up, and then I'll let Anderson. Okay, thank you.
Yes, I'm actually wrapping up.
Thank you.
So what we, in terms of what that did for, what COVID did for us in looking at SRH is that I encourage all persons who are advocates and technicians to be at the table when discussing the national preparedness for emergencies, because there are a number of factors that are taken into consideration when planning for emergencies. And COVID taught us that we don't know for what period we will be under lockdown. We don't know for how longer this will happen. We don't know for how much longer borders will be closed. And so therefore, it has to be a national response. We have women who are pregnant, who need services. We need to provide self-testing for HIV. All these things have to now be at the table as we respond to the SRH needs of the population in times of emergencies, such as COVID.
Great, thank you so much for that, Joan. And I have so many questions, and we do have a few questions coming up, which is a good sign. I'm going to open now the floor for Anderson to share his experiences from the Barbados countryside, so that we can then see if there are any similarities or any differences with our Belize experiences that we've just heard. So Anderson, you are on. You just have to unmute your mic.
Yeah, I'm here. Hi, good afternoon, everyone. Thank you, Joan. I don't know if you all realize how close Joan and I really are. We're very close. And we've discussed some of these things as well with each other. So there are similarities. I'm gonna speak primarily on the similarities, the differences, sorry. And I will try to really be vivid in certain aspects. I'm going to tell you first what we're about, very briefly. Our vision is to have a community where everyone has access to the highest quality sexual and reproductive health, information, education, and services. We've been in existence since 1954, and we really want to have that impact as it relates to sexual and reproductive health. And we've always worked with vulnerable groups, key populations, those at risk for being negatively impacted as it relates to their sexual and reproductive health and their rights. And we're not going to joke about it. Given the scope, it has always been negatively impacted women and those groups that are less powerless in sexual and reproductive health in terms of their needs. In fact, we like to say that based on how the response is negatively or positive sexual and reproductive health, it determines what exactly is really going on in society in terms of rights and in terms of empowerment. So we take it very seriously. I'm gonna go quickly on. I did have a presentation, but I don't feel that given the time constraints and other needs, that is important. We also, more directly to the Barbados climate as it relates to COVID. Joan is very snapshot, so I'm going to try my best. Basically, we have currently 16 persons in isolation. We have 187 persons recovered, and we have had 7 deaths since March or April of this year. The real issue for us, we had really begun our preparation for COVID in December. We had actually been in contact with the Ministry of Health and Wellness in December of 2019, because we were already watching trends, and that's credit to my medical director and really getting those things into being. In January, we had, what can I say? We had a team meeting where we all delivered our protocols. We delivered the liaisons that we had with the Ministry of Health. We had even began looking at our PPE equipment. We had really looked at a number of things prior to what was expected, because the truth is, we didn't know what to expect. So we wanted to plan as much as we can, if there could be such planning as it is. We started a mitigation strategy. And we took the step to liaison with government early. And we actually, in advance, we had offered our support to government with regards to their mitigation strategy, because we had already begun to hear snippets of what was happening worldwide as it relates to sexual and reproductive health and lockdowns and access. So we really didn't know what the extent would be. And we had Joan was in a meeting. She remember when we were discussing with some consultant in the US that gave a very frightening, not just health or but economic, it left us depressed. I actually I actually had a real issue with it, because they were saying that small islands, developing states such as those in the Caribbean, would literally be lost to the first wave of COVID. I would never forget it. And that consultant has subsequently never spoken on a platform again. I don't know, wonder why. Because the government had already began reaching out to us because we have already significantly integrated for the program to the national program, and we were already looking at all those communities and working with those communities that were highest at risk as it relates to sexual and reproductive health. I say we, but we doesn't mean the FP or my team. It means the partners that we already work with. The LGBT organizations, for example, Equals, SEED, Communication, Education, Empowerment and Development, and other partners, even within Bango, the Business and Professional Women's Club, one of our major partners, they were already, getting ready with regards to the possibility of gender-based violence. The National Organization of Women had already made it known that there was a concern of theirs. And we really saw this. And basically we saw this, we tried in our minds to prepare as best as we can. One of the problems that we really didn't know is how exactly COVID would have negatively impacted our society. So therefore, for 2 weeks, we decided as a management team that we were gonna sit down and really assess how it was gonna impact all of what we were gonna do. Yes, we did try to do some preparation as it relates to PPE. We had challenges prior to COVID, so it components some of it, but some of the other commodities that we had access to, we had them in good stock. Our greatest fear was some of our pills. We were really concerned about that because there was a demand already that we weren't fulfilling in terms of our other partners, and we were concerned about that. So those are the things we were concerned about. But the biggest thing wasn't just planning, it's when it came to implementation. And what we found is that the 2 weeks we spent, we really felt the impact of our clients. We had previously taken these steps in the previous year to beef out our social media presence, or Facebook, or Instagram, and we have a WhatsApp liaison for the clinic in terms of, if you can't directly reach us online, there's a WhatsApp number, and then we can directly reach a physician or a nurse. We have already begun planning those things. And when we opened and during the lockdown, and thankfully because of our relationship with government, we were already in the process of receiving our passes to have freedom of movement within the community and within the areas as it was necessary. The truth is, Barbados is a lot smaller than Belize, and in terms of our access, we are close to all of our clientele. And like I said, we work through partners. So our partners were able to liaison with us to their most needs. And again, not to single it out, young people, women, the members of the LGBT community, men who have sex with men, gay men, gay women, female sex workers were disproportionately impacted, especially when there was the closure of freedom of movement to healthcare facilities. I want to say it was not horrible, but it was a little discomfort in adjusting from the way it is used to be. And then again, it was their preference as it relates to stigma and discrimination in terms of going to certain public health facilities at certain times. And so these were things that our partners made us aware of, our clients we interact with were aware of, and the people we already had on the ground made us aware of. So we kind of were led by our partners and the community groups that we work with and the community that was close to us. And we were able to realign some funding that we had already had. We had a project in which we were looking to work with key populations and provide access to services. But what we did differently is that we tried to realize some of that funding, one, to provide PPE equipment, to investigate a telehealth app, which we started, but we are bringing it on stream in a more forceful way. And we wanted to make sure that those clients who were having difficulty affording access to services could. So services are not free. We do them considerably subsidized, but we were making allocations in this special situation because what happened is that we did experience, and for the long haul, we still continue to have to do it. It's social dislocation because of the loss of jobs, because people were unceremoniously severed. Even within that period of time, there were people who were not working. They would have had their little stash, but with time, it would have worn away. So we expected that, and we tried to realize some funding. But we did not expect the demand that we saw. I really, I'm gonna try to share the screen just for, just to show you, one thing. Right, I don't know which one the screen can show you. Yes, I want to show you this. This is our performance prior to COVID. The orange line is the 2020 performance prior to COVID. You can see the months there, and then you can see what happened in March to April, and then you're seeing the response in June. Now, we managed to get other persons to help assist us with funding to help people who were in need, and then you can see that demand increasing, and it's kind of normalizing. I don't think that's a true normalization because the month isn't exactly finished, and we usually have a surge at the end of the month for services. So we've been seeing in our performance, seeing that impact. And just like Joan said, and this is really similarities happen. We are seeing an increase in a lot of the activities that, in terms of needs. Yes, with regards to STIs and STDs, face it, people are home. Some people don't have any money. Some people, the cheapest form of entertainment is sex, and people were having lots of it. You understand? The next thing people were having lots of sex, unprotected sex, and inevitably some unwanted pregnancies happen. We saw that. It's our protocol for pro-choice, so therefore the persons were exposed to all of the options that they could experience as it relates to that. But we noticed that a lot of things we needed to consider, that a lot of people who were also would have been in a different social class and social structure lost their jobs. And even then, we see these as opportunities as well to help more people. Low-cost services at the best possible price. We try to provide limited direct face-to-face contact. One of our biggest challenges is that with regards to our outreach programs as it relates to sexual and reproductive health education directly to schools and directly to community groups and directly to businesses, this did take a great impact. That's one of our flagship programs that we've seen manifest well within the last 2 years. Really, that people want us in their communities. Really, that people want us in their space to hear what we have to say. And that was negative impact. That's, even though that increase and that access, that's those things that really are not money, they're really not numbers, that's for community good. And we've seen negative impact in that. So these are things that we've been on the horizon for. And I really want to credit the team and the partners for really putting us in a good stead. And no, it's not all perfect. No, it's not all great, but we're going to struggle through. We've seen instances, yes. I know of examples of people sex workers, women who've been in relationships and the partner just change. Same things happen to men. We've seen those things. We've seen that the frustration and the negative connotations that sometimes are of human nature manifest during COVID. But we're here to offer the support. A BFPA, our counseling program, or other the social work network that we're part of, they themselves provided support. So there was a whole lot of things going on in COVID that we really took notice of. And credit, we do not expect government to be in a position to assist us as maybe we would like. So we had to prepare kind of, but it's going to be, we're preparing for the long haul. We did experience a reduction of traditional funds. One of the things that we're really concerned about now and still is the increase of crime. And crime has disproportionately impacted some of those vulnerable groups, especially sex workers who are on the street late at night. COVID literally decimated that business. And what happened to those women? That's one of the concerns that we've had and we continue to have through the crisis and the economic recession, they say, but we're looking like we're heading for a world depression. So there are a lot of things that we've highlighted, but for me, successes for me is simple. For example, is that we have seen increased demand for services. We've seen a deepening of partnerships. We've seen the creation of new partnerships. Yes, some faith-based organizations have reached out to us. Some Christian-based organizations have reached out to us. Continued effort and presence of staff commitment. I want to mention that. We've seen the continued relevance for the association. You saw, I think this week, the senior medical officer speaking about with regards to what's going on in terms of HIV, access to HIV to treatment. STIs, there's no doubt that we're going to see an increase in STIs. And what's happened, you've seen that explosion of use of technology, communication for the service delivery, Facebook, WhatsApp, Instagram. We really can't sleep at night. In the introduction of telemedicine, we started, that's going to continue, that's going to roll out this month. But there are lots of things that are going on. And the BFB here is going to be here for those people who need them. We've been here for 65, 66 years, and we're here to be in for 65 and 66 years more. I think that's all I have to say.
Thank you, Anderson. I was just about to let you know you had 5 more minutes.
No.
Okay, go ahead, Monique.
That's fine. Great. Thank you both so very much. So a lot of similarities. Some of the things that stood out for me, and just before we go to the Q&A section, and Kelia will be fielding the questions. And I didn't really want to preempt your conversation or your thoughts, but certainly what also came up that I noted in the conversations going on around COVID, that women and girls were disproportionately affected. And certainly, as both of you have mentioned, increases in gender-based violence, incest, rape, also other vulnerable populations were disproportionately affected. And we're hoping to focus on some of those populations as we go on with our shock series. One of the things that also stood out for me too in your conversations is the importance of partnerships. So with your civil society organizations, being very critical, and yes, of course, with your international organizations providing the support that's needed, especially with the financial support. In Joan's case, with the telecounseling, which I think is a fantastic idea. Anderson spoke about telemedicine, and I mean, I've had my experience with telemedicine, and so that's new opportunities and so on that perhaps COVID has opened up for us. Joan also mentioned, I think, which I don't know if we have experienced this really, undocumented individuals being a new perhaps category of vulnerability within the COVID conversations. And I mean, certainly undocumented individuals were always considered to be vulnerable populations within SRH. But again, the intersecting pandemics, as I call it, being from vulnerable populations and from COVID combining to make already vulnerable situations even more vulnerable. So that's something else that we can look at and talk about even more. One of the things that also stood out for me in these conversations across the globe were that women and children who are seen as to be one of the more vulnerable populations are very much excluded from community-based humanitarian responses. And usually they're seen basically as recipients rather than contributors of any such efforts. And Joan also mentioned being locked down, both of you actually being locked down as vulnerable populations, already vulnerable in abusive homes during COVID. So those are some other concerns.